Welcome, and we're glad to have you here. It looks like we have a good showing on the Zoom as well, a couple of dozen people there as well. It is my distinct privilege and pleasure today to introduce Dr. Michael Morris, who is our fifth Rifkin visiting professor. So I had to think if that's the fourth annual or the fifth annual, but it's great really to have him here today. Dr. Morris is a real leader in the field of genital urinary oncology. We feel very privileged to have him here today. He has distinguished himself academically in many different regards, but recently he's done a tremendous amount of work in this area of Theranosics in lutetium, and it's really an exciting topic, I think, for prostate cancer clinicians, like many of us are, as well as others in this field. So we're really looking forward to this particular talk. I'd say that Dr. Michael Glaudet is in the audience today. Dr. Glaudet was the inaugural holder of the Robert Rifkin Endowed Chair. He's my mentor, my good friend, and it's really a pleasure to have Michael here today. So with that, I'd like to introduce Dr. Michael Morris, who will be speaking today about diagnostics and the changing face of prostate cancer. Dr. Morris is a section head for prostate cancer and the GU Oncology Service at Memorial Sloan Kettering Cancer Center and the Sidney Kimmel Center for Prostate and Urologic Oncology. So Dr. Morris, we're glad to have you here and welcome.
Thank you so much. What a kind introduction. And I just want to also thank you, Tom, for your hospitality. Thank all of the members of your group who've been treating me so well and so warmly. And I haven't seen Dr. Glaudet in quite a bit of time, but I think probably the first time we met, I was a fellow in 1997. So it's good to see you again. We're all getting a little bit older over these decades. So it's my distinct privilege in this wonderful building in a place that's a lot more scenic than New York City is. You got better light and better air to talk about Theranosics and the changing face of prostate cancer. And these are my disclosures. So I think that just conceptually, Theranosics have great appeal for prostate cancer because unlike a lot of prostate cancer therapeutics, which are now getting sort of balkanized into specific groupings, which I'll show you in just a minute, the whole field of Theranosics, depending on the target that you use and the radioligand that you use, has applicability from the high-risk localized patient who has not seen any hormonal therapy, we call castration-sensitive prostate cancer, through the most advanced patient that has been through multiple androgen receptor-directed therapies, who has what we call metastatic castration-resistant disease, or disease that's progressing despite testosterone-lowering agents. So regardless of burden of disease and regardless of treatment history, this is a strategy that can significantly impact the clinical course of the disease. And if you think about contemporary trial and drug development for prostate cancer, it's getting narrower and narrower. We now have genomic subsets that are dependent on their homologous repair defects, and within those who are BRCA2 versus anything else. We have the mismatch repair deficient patients for whom we have now immunotherapy. And even our broadly applied therapeutics like chemotherapy are fit into specific groups of tumor distribution, high volume versus low volume, and AR signaling status, AR positive or AR negative. And even within those, we have synchronous metastases or metachronous metastases. It's been a process of like lymphomatizing prostate cancer, of turning a disease that we used to think of broadly as just prostate cancer or metastatic or high or low risk prostate cancer now into very specific phenotypic and genomic categories. And Theranosics, on the other hand, has applicability to all of these because it can impact disease regardless of its resistance mechanisms, regardless of its prior treatment, regardless of its disease burden, provided that you design the drug appropriately for the clinical status of the patient. So what are the fundamentals of Theranosics, which for those who may not be familiar with the term is a portmanteau of therapy and diagnostics, because you're using the same target and targeting molecule to image the disease in order to characterize it biologically as you are to treat the disease and kill the cancer cell. Well, you need three things. You need a target or a good target, a targeting agent, and a payload. Those three things, which can be configured and reconfigured depending on the disease status and the biology of the patient, are really rationally developed drug development, because you can determine the characteristics of the disease that you're targeting, the characteristics of the clearance of the drug, and the nature of the payload with a deliberate set of decisions, and alter the therapeutic to toxicity balance and ratio. When we're talking about imaging, we're generally talking about positron emitters like gallium-68 and fluorinated F-18. And we're talking about therapy. For this discussion, at least, we're generally talking about the beta emitter lutetium-177 or the alpha emitter actinium-225. Just to remind those who may not be familiar with that, alpha particles like actinium-225 emit a huge amount of energy, but in a very small distance. So in boxing analogies, we say they have a bigger punch, but a smaller reach. And beta particles, such as lutetium-177, they have a greater reach, but a lesser punch. Alpha particles can't pass through even paper, but they destroy almost all cellular material or DNA-based material between the emitter and that piece of paper, whereas beta particles have less destructive capabilities, but can pass through paper, but generally not lead shielding, for example. So let's talk about how Theranosics has developed now and its applicability in prostate cancer. First of all, we recognize that we all stand on the shoulders of those who went before us, and you'll see Dr. Skip Heston on this slide, who did the original cloning of a target that we use now very commonly called prostate-specific membrane antigen, or PSMA. You can see that he developed the cDNA of PSMA. PSMA is a protein that sits on most prostate cancer cells. And basically all of that coding translates into this protein, which is on the left-hand side of the slide. It sits on, in the prostate cancer cell membrane with a large extracellular domain, a transmembrane domain, and then the smaller intracellular domain. But it's that extracellular domain that's so appealing in terms of making it a target for especially Theranosics, but even for just pure diagnostics such as imaging. It functions biologically as a transmembrane glutanyl carboxypeptidase. It's expressed advantageously from diagnosis to the most advanced disease in most patients. It's expressed regardless of distribution of disease, whether it's in the prostate itself, or whether it's in lymph node metastases, bone metastases, even soft tissue disease, which of course is the minority of patients. Its expression varies by a function of androgen receptor signaling, so it can be manipulated with hormonal therapy. It has very limited expression in normal tissue. And I think what's been underappreciated is expressed on the neovasculature of every single non-prostate solid tumor. And so we've imaged patients with breast, colorectal, melanoma, RCC, bladder cancer. You're talking about a target that is relevant to all of those diseases and has just not been appreciated for its utility in exploring in those diseases, both its diagnostic and its therapeutic use. It's silly that it's called prostate-specific membrane antigen, but then again, when we think of most nomenclature that says that something is specific biologically, it's wrong, right? So it's really not prostate-specific membrane at all. The inception of PSMA PET is critical to the development of Theranosics in prostate cancer, and originally started with antibody-based therapy. And I have to give credit to Steve Larson, one of my mentors, and one of his junior people that's been sort of my partner in arms, Nita Pandit-Taskar, doing some of these early imaging trials with the intact antibody that targets PSMA called J591, which was discovered by somebody named Neil Bander, who's still a close friend and colleague. And this was the first time that we could actually see prostate cancer in its true state in terms of metastatic disease. Previously, before PSMA PET, we could only see the derivative effects on bone through bone scintigraphy, a technology which developed in the 1950s and then came to fruition in the 1960s and still is used as standard of care imaging of bone now, but still gives you really no sense of the tumor itself. But PSMA PET allows you to query directly the prostate cancer itself. And so you can see much more clearly what's going on inside of the patient's bone compartment and directly visualize the disease. What was crucial to advancing from those first initial forays into PSMA-based PET imaging to where we are now is the development of these small PSMA-targeted molecules by Marty Pomper, a scientist at Johns Hopkins, who developed the urea-based small molecule that is now the basis of pretty much all PSMA PET imaging and most of PSMA-based therapeutics. They all have in common a urea core. And you can see on the far right here, DCF-PYL, which is an F18 PSMA PET tracer, PSMA-11, which is a gallium-68 PSMA PET tracer. These are the current FDA-approved PSMA PET imaging agents. They're quite similar to the current approved PSMA-617, which is the FDA-approved PSMA therapeutic. So PSMA PET was only recently approved in 2021 by virtue of a collaborative effort of many of us around the world, and to generate these data for regulatory recognition by the FDA. And the reason for that approval really lies in its specificity and its positive predictive value. You can see things on a PSMA PET that you can't see on any other image. But the real question is, when you do see something on a PSMA PET, can you believe that it's cancer? And by virtue of the fact that it has a specificity of 95 to 100%, the answer is it's really unlikely that it's a false positive. You can pretty much take to the bank that it is PSMA expressing tumor there. And the most likely candidate for PSMA expressing tissue is, in fact, metastatic prostate cancer. The positive predictive value, meaning if you see an abnormality, how likely is it actually to be cancer, is quite good. And you can see that these numbers are pretty much uniform in the same category between the gallium-68 and the F18 radiolabeled tracers. From my perspective, and I think a lot of people in the field, the best PSMA tracer that you have is the one that you can get your hands on. Many patients will say, well, should I get the gallium-68 or should I get the F18? Whatever you can get, it's better than what the alternative is. This is really, for those who are unfamiliar with prostate cancer, transformed our disease. So if you look at this patient, which is not some extreme iteration of what PSMA PET can do, this is the MRI of this patient's prostate. It has a lot of high-grade disease in it. His bone scan really doesn't show very much in the way of metastatic disease. There's this little thing that was over here that we thought maybe it could be metastatic disease, maybe not. He has an artificial hip. This patient was going to go to surgery, have his prostate taken out, and we figured relatively low pretreatment PSA. Perhaps then he has some shot, he's still high risk, but some shot at cure. But then if you look at this gentleman's PSMA PET, which was taken the day after this bone scan was taken, you can see that this patient is replete with metastatic disease that would otherwise have been undetected and unseen. And this patient would be destined to relapse and would in many ways have simply been undertreated if the only appreciation of his disease was that he had high-risk localized disease. This patient should clearly go on to a clinical trial that involves some systemic therapy, because otherwise, in a few months, those otherwise occult PSMA-avid metastases would become symptomatic or otherwise evident metastatic disease. Getting a prostatectomy alone, maybe would do some good for this patient, but this patient has a systemic disease and requires systemic therapy in order to prolong his life. So as a result of that, the entirety of the prostate cancer spectrum of disease and how we conceive of its staging is being revisited. So a significant percent of folks with otherwise felt to have clinically localized disease or strictly biochemically relapsed disease, they actually now, we appreciate, have metastatic disease. What we should call those patients is still under debate, but I'd suggest that just molecularly defined metastatic disease would be adequate, and we would all understand what we're talking about. And at the same time, patients that we otherwise were on hormonal therapy but we have no disease that we can see, called non-metastatic CRPC. Those high-risk patients, almost all of them are getting recategorized now into metastatic CRPC because of a study looking at those high-risk patients, 98% of them had positive findings on a PSMA PET. 50% of those patients with non-metastatic CRPC had outright metastatic disease. And so we're reconceiving now all of our risk models, all of our staging models, and by implication, all of our treatment models need to be revisited as well. Our nomenclature needs to be redefined. Our treatment paradigms need to be defined. I can't overstate how the approval of these agents last year has changed our whole pattern of understanding prostate cancer in today's day and age. But one thing that it's also done is opened up the doorway for therapeutics. Now that we know that we can use positron-emitting tracers to detect PSMA-avid disease, what prevents us from taking off the positron emitter and putting on a beta or an alpha emitter to kill that prostate cancer, to deliver enough radiation in order to obliterate the prostate cancer cell where previously we had identified it? And that brings us to lutetium-177 PSMA-617, which I know is a mouthful, but so be it. We'll all have to learn how to say that. I suppose you could say Pluvicto as well, but I like saying lutetium-177 PSMA-617. But maybe we'll just say lutetium PSMA. So the way that this molecule works, just like the PET tracer, is that the whole molecule attaches to PSMA, to its external domain. It's integrated by endocytosis into the interior of the cell. It's then released into the interior of the cell where the lutetium damages the DNA, leading to apoptosis of the cell. And then it's released. The PSMA molecule recycles back to the cell surface if it's still viable, and the drug stays inside the prostate cancer cell for up to weeks, irradiating it and its neighboring cells. A lot of the early work in prostate cancer was done by the good colleagues that we have in Germany off clinical trials, and then by our colleagues in Australia on some early phase prospective studies. But what really led to the approval of PSMA-617 and the formal enumeration of its benefits clinically into actually, does this drug prolong survival, delay disease progression, and improve quality of life? That's dependent on this study, the VISION trial, which many of you are familiar with and which you guys as a center were active participants in. So many of you are very familiar with this trial, both for its benefits and for its warts, for which there are some. But basically, this was a clinical trial for the latest prostate cancer patients in the spectrum of their clinical course. These are patients who are refractory to just testosterone-lowering agents, refractory to more novel hormonal therapy agents, and refractory to at least one line of chemotherapy. So these patients were essentially progressing through the three core treatments of prostate cancer. They had to have a positive PSMA PET scan by virtue of the gallium-68 PSMA 11 PET. It was pretty easy criteria actually to get into this trial on the basis of those eligibility criterion. Only about 13% of the patients did not get into the trial on the basis of their PSMA PET. And the patients were then assigned to an acceptable standard of care as defined by their clinicians and randomized to either just that standard of care or that standard of care and lutetium-177 PSMA-617. By implication, that means you cannot have drugs that you can't combine with this therapy as part of this trial, meaning chemotherapy. We don't know how to combine chemotherapy and lutetium. We don't know what you would need to dose modify. They both would damage marrow. And so patients could not be randomized, could not be assigned to a chemotherapy standard of care or a radium standard of care as part of this trial. That's generated some discussion, shall we say, about the control arm of this trial. But nonetheless, that was the trial as it was designed. It had two primary endpoints. One was overall survival, and the other one was radiographic progression-free survival, not defined by PSMA PET, but instead defined by standard imaging. So just to show you where this trial was positioned, it really was at the tail end of the disease. Many of you may not be familiar with how we treat prostate cancer, where in the clinical course we use many of these drugs, but suffice it to say that in an inexorable march from year to year, most of our most active therapies for our most advanced patients are now applied very early in the disease. So pretty much at diagnosis of metastatic disease, our best hormonal therapies and chemotherapy is applied. These patients then become resistant to those treatments relatively early on, leaving the category of second-line therapy for metastatic CRPC basically an empty vessel. You have a few drugs that are applicable, but not very many. And this is the place that the VISION trial was positioned. These data show the benefits and the limits of lutetium, basically. So the top curves are the PSA declines, and the bottoms are radiographic response. So the benefits in terms of an anti-tumor effect of lutetium is you get a lot of patients who otherwise would not have responded to any therapy responding to the drug. Nearly 50% of the patients have a profound and significant PSA decline. But at the same time, there are some patients who really don't respond. And so I say that in order to convey to you, to convey to patients, to have equipoise that this is not a curative win-all therapy. That is, I think many patients think they must get this drug under any circumstance for any clinical scenario or life will fall apart. And the reality is that we're talking about a drug that has a significant impact in terms of cancer control in half the patients, and the other half we need to do better for. And that came from me, so that everyone knows I'm not going to stand here and say, we're done with lutetium, nothing more to develop. We're all set. We have created the new silver bullet for prostate cancer. Half the patients still do not have an adequate response to this therapy. It is amazing that we do have about a 10% complete radiographic response to this therapy. That is unheard of for this patient population. And it is equally amazing that 42% of the patients with accessible disease have a partial response. But we should also keep in mind that 47% have stable disease in reaction to this, and 45% have progressive disease. So I recognize that this is a really incredible advancement in terms of anti-cancer therapy and anti-cancer effects for patients who otherwise had very few treatment options that are effective, but we need to do better. Let's translate these interim endpoints of radiographic response and PSA decline into what are the side effects that these patients may face. So around 40% of the patients will have some infusion-related nausea in particular, not so much vomiting, but nausea. That's treatable with pre-medication. Around 8% will have significant declines in their platelet counts, and around 13% will have significant declines in their red blood cell counts. A fair amount of patients will have low-grade xerostomia, but unlike other radioligands, none of these patients had significant xerostomia. So that's basically the side effect profile. It's better than having progressive disease. It might be better than second-line chemotherapy, but it's a relatively tolerable therapy for a patient who otherwise would be facing basically supportive care, hospice, and other palliative measures. Here are the primary endpoints of the trial and the true clinical benefit of lutetium plus the standard of care versus the standard of care alone. So about a 38% reduction in the risk of death, a 60% reduction in the risk of progression of death, and a 50% reduction in the risk of developing a symptomatic skeletal event. In hard and fast terms, that's about a 4-month absolute median improvement in overall survival in a patient population that otherwise, without lutetium, lived less than a year. If they received lutetium, the median was 15 months. In terms of other potential real tangible quality of life events. It not only helps you live longer, but helps you live better for longer. In other words, delays the time to deterioration in quality of life and delays the time to the deterioration of pain control. So you're living longer and you're living better. And we would say that that's a success in a patient population that generally progresses at 3 to 4 months and dies within a year. So I think that for this patient population, this is a good treatment option. How about taking a deeper dive into some of these data? Is there any signal that the combination of lutetium with any other permissible therapy in vision, is there some combination that seems to do better than others? And the answer to that is yes. If you look at the patients who received lutetium in combination with even a second, third, or fourth line androgen receptor directed therapy, they did seem to do better than those who received any other form of therapy in combination with lutetium. So you can see the survival curves. These are the patients who received lutetium and another androgen receptor pathway inhibitor. These are the patients who received lutetium without an androgen receptor pathway inhibitor. Of course, both of them are doing pretty well than relative to those who received the standard of care alone. But it does suggest that it's not just lutetium that one should think about, but lutetium plus what amplifies the treatment effects. This doesn't answer that definitively, but suggests that there is something to androgen receptor signaling, PSMA expression, and targeting PSMA that works well. And that's something that we should probably explore more formally in future trials, and which is what we're doing. How about the inevitable question that patients ask, or clinicians as well? If my PSA goes down, am I benefiting from drug? Historically speaking, that's a hard question to answer because PSA declines don't necessarily translate into living longer in many types of therapies. In this type of therapy, it does seem like a pretty good correlation. If you look at those patients in terms of both radiographic progression-free survival and overall survival, those who had the best decline, greater than 90% decline, well, they progressed at a median of 20 months, and those had no decline, 3.5 months. There's a big difference between those. So and in terms of overall survival, those who had a 90% or greater PSA decline, we're not even at their median, and we're 2 years out from the trial. These data were just presented a couple of months ago, right? So those patients are doing really well. Those who had no decline, they lived on average about 9 months. So it does seem like if your PSA declines on this therapy, it's probably a good thing for you. How about PSA response and quality of life? Same thing. The greater your PSA decline, the more likely it is you're going to have a preserved quality of life. A greater than a 90% PSA decline on the trial led to a median time to degradation of quality of life of just under a year at 11 months. No decline. Within 3 months, your quality of life was deteriorating. So again, I think for the clinician and patient question, is it a good thing if your PSA is declining well? Yes. Is it a bad thing if it isn't? You probably should be thinking about when you're going to transition off therapy, if there is another alternative, or what you could combine with the lutetium that might be better, or perhaps a different radioligand. In terms of this relationship between rPFS and overall response, this is a complicated slide, but historically, we are moving in the field away from overall survival to radiographic progression-free survival as a primary endpoint for many clinical trials, based on a historic association between rPFS and OS of around 0.7 to 0.8, and that association held up for this as well. So I think that when we design future trials, should we think of rPFS as a legitimate primary endpoint for future phase 3 studies for prostate cancer using radioligand therapy? The answer would be yes, because rPFS and OS is holding up as an association for this class of drugs, just as it did for the novel hormonal therapies that had rPFS built into those trials. It bears special mention to talk about the therapy trial. This is an Australian trial that is a randomized phase 2 study in which patients were selected for eligibility not just on the basis of a PSMA scan, but use of both a PSMA scan and an FDG PET scan, so that you could look at the mismatches of disease and select out those patients who had PSA negative but FDG avid disease. The Australians have made much of this selection criteria as specifically enriching their trials for patients likely to benefit from lutetium. So keep that in mind as you look at these data. Now, these patients were randomized to either lutetium-177 PSMA-617 or to second-line therapy with cabazitaxel. This offers some insight into what VISION didn't, and that is it contains chemotherapy in the control arm, which VISION didn't. So we could possibly get an early view from a randomized phase 2 with survival as a secondary endpoint into the benefits of lutetium as opposed to chemotherapy. But remember that this trial is specifically enriched for PSMA radioligand therapy responders. And much has been made of the fact that if you look at the PSA declines on these patients, 66% of the patients on the therapy trial had a significant PSA decline, whereas in VISION, only 45% did. So there's this argument that's out there that perhaps 2 scans is better selection criteria than 1 scan in selecting patients for radioligand therapy. On the other hand, if you look at overall survival, there is really no difference between cabazitaxel and lutetium-177 PSMA-617, despite the fact that the PSA decline rate was higher in this trial, and actually it looks like it's pretty much just as good as chemotherapy, which means, first of all, that in this trial enhanced for radioligand therapy, that chemotherapy looks like it's just as good. We should think about the fact that there are probably 2 standards of care for these patients. One is lutetium, and the other is chemotherapy. So a lot will go in terms of the future decision making that we have as to how we can better select patients for receiving lutetium to be optimally selected for prolonged life, and also the impact on quality of life, and which cancers are more amenable to one therapy versus another, and which patients are more amenable to one versus another. There's a lot of work to do, in other words, to distinguish between who should get lutetium versus who should get cabazitaxel. Now, there are some early nomograms to help with those predictions of who should get lutetium at least. And I think one of the most important in terms of looking at these nomograms is, first of all, there's very little that's surprising here. These are prognostic models. And so what do we know generally is prognostic for life at the end of this disease? Well, the more disease that you have, the worse off you are. The lower your hemoglobin, the worse off you are. If you have liver metastases, no matter where you are in your disease, you're worse off. No big surprises in this model. But it's important to see that the pretreatment PSMA scan is quite prognostic in terms of who will do best with radioligand therapy, as assessed by something called the SUV mean. That's the total average of all of the pixels in the PSMA scan. And the cutoff looks like that it's evolving around an SUV mean of around 10 in order to distinguish both prognostically and predictively those who do best on lutetium, at least as radioligand therapy. It's no surprise that that's at least the early signal on that. The PSMA scan is in essence a surrogate for dose of radiation. The more PSMA that you have, the more drug that will come to the cancer. The more drug that binds to the cancer, the more radiation that the cancer receives. And we know from earlier studies by John Violet, who unfortunately passed away recently, that more radiation leads to a better response. This is, in essence, a type of radiation therapy. The more radiation therapy that you can get into the tumor, generally speaking, the more cancer that you can kill. But we also know from vision that PSMA PET is prognostic for at least progressive disease uh, in terms of the patient population that received lutetium in that study. We didn't look at the control arm yet, but the higher your SUV mean is on the pretreatment PSMA scan, the better off you did in terms of rPFS. And you would think, okay, that seems very straightforward. That's my take-home message. But when you look at overall survival and the prognostic value of that pretreatment PSMA scan, it's a lot more complicated because only the patients with the highest SUV means on the PSMA scan seem to jump out of the group as having the best overall survival. The bottom 3 quartiles seemed all just to live just as long as each other. And how we can explain that, I don't know. Anyone with a lab, please let us know because it's hard to reconcile this slide with this slide. How can you progress more slowly if you have a higher SUV mean and not live longer? So I think that there is a lot to figure out here. That pretreatment PSMA scan was given a signal at not just being prognostic, but predictive as well, as presented by Mike Hoffman at last year's GU ASCO, where he looked not only at the lutetium arm, but the cabazitaxel arm as well. And a PSA with an SUV mean that's greater than 10 appears to be highly predictive of responding to at least the lutetium. So there's a lot of signal to be sorted out here for that pretreatment PSMA scan as a prognostic variable and as a predictive variable. And hopefully in the next several studies that are coming up, we'll have better information on that. And we are creating a new nomogram based on vision so that you can have good phase 3 data to start parsing together exactly what factors contribute to what in terms of at least prognosticating for overall survival on lutetium. So how can we do better? Well, for one thing is get more energy onto the payload. And actinium, as I initially started talking about at the first couple of slides, is one method of doing that. This is a patient treated by our European colleagues. He progressed through lutetium and had a massive amount of disease with a PSA of 3,000 and pretty much an axial skeleton full of disease after lutetium lutetium was used for him, and had pretty much a complete response after a few doses of actinium-225 PSMA directed therapy. So just getting radiation into the tumor at a higher dose may be quite effective. As you might imagine, though, it has more toxicity. So you can see the patient's salivary glands over here, and that's because salivary glands express PSMA. You do not see salivary glands to the same intensity over here, and they're nearly gone over here. So severe xerostomia is a problem with serially treated actinium-225 patients because you can effectively obliterate the salivary glands as well as your cancer. It's a lot of energy going into the salivary glands, and probably small molecules to deliver actinium have their limitations unless we can figure out a way to address this. But that will bring us back to antibodies. Antibodies don't bind to the salivary glands. And so, sort of back to the future, we started out with antibodies and decided to go with the small molecules. Now we're looking at the antibodies again. The other strategy to optimize lutetium follows that well-trodden path that I talked about before of just moving therapy earlier. Everything tested except for perhaps radium works better when given earlier in prostate cancer for a number of possible reasons. So that is being done. If you look at pre-chemotherapy metastatic CRPC, remember that vision focused on the post-chemotherapy population. The PSMA-4 study is now done as of about 6 weeks ago, completely accrued. This is a 1-to-1 randomization of patients who have progressed on one androgen receptor pathway inhibitor, and they were randomized to either a second ARPI or lutetium for 6 cycles with a primary endpoint of radiographic progression-free survival. This trial is finished. We hope to report it next year, and we hope to know whether patients live longer with this therapy in the pre-chemotherapy space, and if so, by how much more? ENZA-P is another early metastatic CRPC study. This is ENZA plus or minus lutetium as first-line therapy for metastatic CRPC, second-line ARPI directed therapy. And this, from what I hear from the folks in Australia, from Louise Emmett, should be reported at your next major meeting. And from what she tells me, has pretty good results. So we'll see. What about even earlier than that? Remember that most of these therapies that you see up here are in the castration-sensitive space because they were moved before metastatic CRPC and worked even better in CSPC than CRPC. And that is the PSMA addition trial, which you guys are in the process of activating now. This is a collaboration between the Cooperative Groups Alliance and NRG and Novartis. So it's a academic industrial collaboration with NCI and Novartis input and support. These are for patients who are going on to ADT and the ARPI of physician choice, plus or minus 6 doses of lutetium with a radiographic progression-free survival primary endpoint. This trial is just open and accruing now. So it will be a while before we have a readout on these because these are treatment naive, newly metastatic patients. It's going to be many years before they actually progress. And we'll know then whether 6 doses so early in the disease course will have a major impact. There are those who are skeptical that 6 doses will have a major impact because it's all front-loaded therapy and they have so many other therapies that they will face in terms of later treatment for CRPC. But for those doubters, remember that you do see that effect of prolonging survival with 6 doses of chemotherapy for this patient population. And that's why we're now all switching to triple therapy for newly diagnosed metastatic disease. So even though it is a limited amount of therapy, it doesn't mean that you can't see those survival benefits long past the CSPC space into advanced CRPC. And then there's the upfront PSMA trial, a combination study of serially administered docetaxel and 2 doses of lutetium. This is an Australian trial that is an early phase study, but also explores the castration-sensitive metastatic patient population. There are even trials looking at lutetium in clinically localized disease, and there's a rising PSA study that will probably open soon as well. So you're seeing that movement early with this therapy. Obviously, we'll need to look at that toxicity to benefit balance as we treat these patients early. We'll need to develop new treatment models as to what to do with the PSMA avid but not otherwise metastatic patient population in this early disease setting. Are we going to call those patients early disease or late disease? We haven't quite figured that out yet. But moving into the earliest disease phases of prostate cancer is happening and is almost inevitable as a development pathway for this disease. So if you look at the proposed optimization strategy, multiple PETs, high PSMA expression thresholds, dosimetry. I haven't talked about genomic profiling, but certainly we speculate that the HRD patients will be more sensitive to this type of therapy than the others. There's combination therapy with PARP inhibitors and immunotherapy that are looking pretty good in combination with other AR inhibitors and combinations of both the alphas and the betas. Those are all proposed, but the only thing we have right now is one pretreatment PSMA PET, and so that's what you're going to use. And that's all that, and perhaps that's all that you need. We will see how many of these proposed biomarkers to optimize treatment actually play themselves out as successes. And remember, we're talking about a therapy that at its baseline is resource, requires a lot of resources, financial and otherwise. New buildings need to be built. Patients have to have access to PETs. Patients require multidisciplinary care. The more biomarkers that you add, the more patients that you exclude. And so we have to think about what's that balance of inclusion versus optimization and how many social resources will go into each. We have new targets other than PSMA that we're exploring. I'll just mention these by name because the limits of time dictate that we just cruise through these. But for one thing, there is a nice pan solid tumor marker called STEAP1 that we've already done extensive imaging studies on in conjunction with an ADC that we explored a few years ago. So these images were our patients who received STEAP1 imaging. You can see it's extensively expressed in prostate cancer. There are antibodies that can target STEAP1, and so I'd say from a qualification standpoint, this is qualified as a target for future theranostic studies. There's HK2. HK2 is similar to HK3, and you all know HK3 by another name, and that is PSA. HK3 is human kallikrein 3, and PSA and HK2 are co-localized on the same chromosome. And where you see PSA, you'll see HK2. And basically, HK2, unlike PSA, is bound to the cell membrane. So you can image it, as you can see over here. This is a patient that we imaged with a indium-111 radiolabeled antibody, and it does not have salivary gland uptake, unlike PSMA. So right now, against HK2, there's a theranostic with actinium. There's a bispecific antibody that conjugates both with HK2 and CD3, and there's a CAR T-cell directed therapeutic program against HK2 as well. So lots of drugs are being developed against HK2. B7H3 has a lot of ADC data now from two different sponsors targeting B7H3. B7H3 participates in immune checkpoint inhibition, but is expressed in a range of prostate cancers, is prognostic for that, and could be a therapeutic target as well beyond ADCs and developed as a theranostic. So there are a lot of targets. Neuroendocrine prostate cancer, a huge problem in the day of ARPIs with lineage plasticity and reversion of adenocarcinoma into a neuroendocrine phenotype. DLL3 is a very promising target for small cell lung cancer. TROP2 is another small cell target that could be used for neuroendocrine prostate cancer. And our labs have now produced a DLL3 zirconium PET tracer and a lutetium therapeutic targeting DLL3 that we hope to put in humans pretty shortly. So here's a summary of all the sort of currently, or many of the currently ongoing clinical trials in prostate cancer. You can see that it's a really now rapidly expanding field from a type of therapy that was relatively esoteric and confined to a couple of investigators around the world, to now whole families of drugs that are being developed across the disease spectrum in prostate cancer. And I think that all of this should offer a lot of hope and promise, not just to young investigators, but to patients and their families in particular, because it's they who ultimately will be participating in these trials and defining for us what the benefits of these approaches are. So to conclude, I think that this is an exciting and new member of the prostate cancer therapeutics armamentarium for prostate cancer across the spectrum of disease. The therapeutic possibilities are really opening up in earlier patients. We will need new trial designs and endpoints for those very earliest trials and new biomarkers to know who most benefits from these. But I think that this is really a great day and age for this new drug class in prostate cancer. And with that, I thank you for your attention.
Well, it was just a wonderful talk and in a very exciting area in prostate cancer therapeutics and diagnostics, honestly. So we have a good number of people on the live link, so we'll look for questions there, and we're open for questions in the room as well. Dr. Costello.
Sure. Sure. So let's.
You want to repeat the question?
Sure, I'll repeat the question for anyone who's on the Zoom. So the first question is the role of false positives in PSMA PET imaging. And the second question is mechanisms of resistance through PSMA-directed therapy. So we were pretty rigorous in our definition of what a true positive and a false positive was in those uh, original qualification studies, and called anything that wasn't prostate cancer that was essentially proven by a multi-component standard of truth panel as a false positive. Meaning, if, for example, we picked up an errant lung cancer or esophageal cancer or male breast cancer, and even though it was PSMA expressing, but it wasn't prostate cancer, we called that a false positive. If we saw a tiny little ditzel in the pelvis that was a few millimeters and we tried to biopsy it and we didn't hit it, and so we couldn't histologically prove that it was, and it didn't look like it was a positive by any other imaging means, but of course every other imaging means is inferior to the one that you're using, we would call it a false positive. So there are false positives. There are really other benign entities that express PSMA that could be false positive as well. The ganglia of nerves expresses PSMA. Some components of the gut express PSMA. Kupffer cells express PSMA. So those could generate false positives as well. But because the specificity is high, I think we can, with skilled readers, figure out who's who. And I don't think that second primaries really are false positives. If you have a lung cancer, you sure do want to know about it, right? So that's a false positive from a regulatory standpoint, but clinically a valuable finding. The false negatives, though, are really important because I think many people get a PSMA scan. If they see no disease, they believe that there is no disease. But it has a sensitivity of only 40%, meaning a significant false negative rate. So I would never de-intensify therapy on the basis of a negative scan. If you have a patient who had a prostatectomy and now has a detectable PSA, but has a negative PSMA scan, by all means, give that patient salvage RT. Because just because they don't have a positive finding in a PSMA scan doesn't mean that they don't have disease. It's just too small to be seen. It's not PSMA microscopy. It's PSMA PET imaging. And PET imaging can't detect infinitesimal amounts of the disease. So it's a really important question that you asked in terms of how to use PSMA PET. In terms of mechanisms of relapse through PSMA-directed therapeutics, I think that there are several mechanisms. The first is you're delivering adequate doses of radiation, but the treatment emergent disease doesn't express PSMA. PSMA nil disease emerging through PSMA-directed treatment. That patient population does not need actinium PSMA-directed therapy. It will go nowhere. Well, except the salivary glands. You'll give them good xerostomia, but you won't help them. Those patients should get other therapy. You know, I would rebiopsy those patients, figure out the genetics of it, and give them therapy if that's neuroendocrine disease, give them chemotherapy if it's driven by a targetable pathway, put them on a study. The other patients, though, who progress with PSMA-avid disease, that could well be a dose issue. And they could get PSMA-directed actinium in Germany or on a clinical trial here in the US. So I think it really depends on why you think that that patient is breaking through. Is it a dose issue or is it a biologic issue in terms of not expressing PSMA? And then finally, you could be expressing PSMA, but have some other driver of disease that despite lutetium or even actinium is going to fuel more disease. And those patients, again, they're not going to necessarily benefit with more treatment. So I'd see like 3 categories.
We may have a question on the live stream, it looks like,
Yeah.
too.
We actually have 3 questions on there. Dr. Bennett Chin first wants to ask, of the many newer agents and developments, which one are you most personally excited about?
Well, I'm most excited about the ones that work. You know, Christian Horner, who is the coach of Red Bull's Formula One team, his daughter asked him, "Who's your favorite daughter, Daddy?" And he says, "The one that's winning for me the most now." You know, I don't think that it's a question of what's your favorite target. My favorite approach is find out what target is present in the disease and use the drug that targets that. It's enhancing clinical trials so that we move beyond, just all comers entering clinical trials and then deciding that drugs don't work because it's the wrong treatment population. So my favorite drug is the one that actually targets the patient that has the target there. I wouldn't say like HK2 is going to be better than PSMA unless it's an HK2 positive patient. And I wouldn't say that DLL3 will be the best one for a given patient if they don't have DLL3 positive disease. So the approach is to not have to make a guess like that. You define the biology of the disease with an image, and then you select off the shelf the treatment that's appropriate to the target that's expressed on the tumor.
A certain amount of pragmatism is important in our world. I would agree
Yeah.
with that completely. So maybe go to a question in the room here. I'm going to walk over to Professor Godet and give him the mic so he can ask his question.
Michael, great talk. Can you just comment on the relationship between PSMA expression, particularly with scanning,
Yeah.
and ADT approaches or bipolar testosterone approaches? What happens to the modulation of PSMA and how does it affect the scanning?
Sure. This is one of the trickiest questions that we have now. So historically speaking, when we were younger, we would say that PSMA expression is inversely proportional to AR signaling, meaning if you suppress the AR signaling, PSMA expression would rise. And the world seemed simple that way. So then we would say, okay, let's enrich patients for PSMA expression and add an AR inhibitor and then hit them with a PSMA-directed therapy. But the earlier disease patients don't look like it's that straightforward. The patients with castration-sensitive disease, half of them, when you put them on an androgen deprivation type therapy, will have a blossoming of PSMA-expressing disease in a PET scan, meaning that PSMA is probably being upregulated by downregulating AR expression, our old traditional conception of it. But the other half of the patients can have a marked reduction in PSMA expression as a result of inhibiting AR signaling. So first of all, this is very confusing in terms of developing a rational treatment strategy for the castration-sensitive patient. Second of all, it makes translating PSMA PET imaging into a response assessor, because we don't really have a good radiographic response assessment tool in prostate cancer, even more complicated. If we thought that bone scan flare was complicated, now we've increased that multifold, because now you'll have PSMA scan flare or PSMA scanned depression of PSMA expression. And one is not really a progression and the other is not really a response. And so we have a lot to figure out on that from a therapeutic standpoint as well.
It's about the top of the hour, so I know some people have to excuse themselves, that's fine, but we're going to go through a few more questions
Sure.
if that's okay with you, and then there might be one more here or two more from Adele.
Yeah, so Dr. Kavanaugh asks regarding the question of SUV predicting response, were you saying that it's the average SUV of all visible lesions that's predictive or different SUV metric?
So what looked like it is playing itself out is something called the SUV mean, which is the mean of all of the pixels of the totality of disease. Now, this is not something that you can just eyeball, right? This involves advanced software to look at all of the lesions, look at all of the pixels and average them out. So the SUV mean looks like it is at least a leading candidate for a predictive and prognostic biomarker. The problem is that you don't get that on your average workstation. So it's a nominal significance to your average radiologist reading the scan. He can't tell you what the SUV mean is. So that's a problem to have a leading candidate biomarker that only a small group of people over the world can use. But it is the mean of the pixels across the disease.
And Dr. Jennifer Ricker asks two questions. Let's see, is there any correlation between the expression of PSMA in the primary tumor and Gleason score? That's the first question. The other was the better results when combined with hormonal therapy. Does that mean that you are hitting the cells two ways or that you're hitting different populations of tumor cells?
All of the above. So let's deal with the first question first, which was how does PSMA correlate with Gleason grade? And again, we used to say that the higher the grade disease, the more PSMA expression was seen, and that PSMA expression was ideal then because as a target, it was most appropriate for our most aggressive patients. But now we appreciate that higher grade disease is frequently that 10 to 20% that don't have adequate PSMA expression because they have lost the normal architecture and apparatus of a normal prostate cell, which includes PSMA production. And as you move into the neuroendocrine sphere, you get less and less PSMA expression in the parenchyma of the disease and more in the neovasculature of the disease. So it's a complicated question. The spectrum of the disease, though, does include non-PSMA producing tumors, especially in the higher grades of disease and the more poorly differentiated forms of the disease. The second question, just remind me what it was?
Combining enza
Oh.
with lutetium and maybe two different
Yeah.
targets.
So prostate cancer is very heterogeneous. And if you have a patient with 10 different lesions, I would think of that patient as having 10 different diseases. Some lesions are going to respond just to the hormone, some to the hormones and PSMA, and some will, as we were talking about before, perhaps develop resistance mechanisms to either or both of those in the course of treatment. And I think that as the disease progresses, not just with these two therapies, but any therapies, you constantly need to reassess the blend of disease to know what you're going to treat with next, making it a very tricky set of decisions as you move along.
Well, maybe for our last question, we'll have Professor Nordin pose this.
Sure thing.
So in light of your statement that earlier the treatment, the better, for patients that have had prostate ablation, but not yet any evidence of rising PSA, is there
Yes.
any value in imaging?
Good question. I hope to find that out. So we don't know the answer to that. I think that the best time to do that image is not after that their prostates are out, but before. So that you can make a treatment plan that accommodates the totality of the disease. But there are many patients who come in and say, well, I've had my prostate out and my PSA is nothing. Can I get a PSMA scan? And the answer from a purely technical standpoint is, I doubt that because your insurer will not pay for it. But what utility will it be if we can detect disease, and in whom should we be doing that? Remember that prostate cancer is a really common disease, and we could really deplete society's coffers by scanning everyone who's had a prostatectomy for residual disease with a PSMA scan. How much money would you need to spend in order to detect the one actionable lesion, and what would that actionable lesion be? Now, I do see plenty of patients who have had a prostatectomy and maybe 2 lymph nodes removed, and with the report saying that they had a pelvic lymph node dissection. And when those patients relapse, they relapse in the pelvis. If you look at the gallium-68 rising PSA study, most of those relapses that they picked up in that registration study were pelvic lymph nodes that simply hadn't been removed at surgery. So there may be a role, but how do we select those patients who are more likely to have a positive finding so that we're not just scanning everybody who's had a radical prostatectomy and has no PSA?
Well, with that, I'd just like to again say a sincere thank you for joining
Thank
us
you all for
today.
your attention and hospitality.
Absolutely. I'd like to thank the Cancer Center for coordinating this meeting and so forth. There's 2 other quick things I'd like to note. So you again are the 5th speaker. We keep track of this and celebrate the people that have been with us over the years. So
Very
your
nice.
name will join Sam Denmead from Johns Hopkins, Meg O'Brien from the American Cancer Society, John Gore from the University of Washington, and Tanya Dorff last year from the City of Hope. So we're very proud to
I'm in
do
good
that.
company.
You are in very good company. And then we just have a small way to recognize
you
your
very much.
presentation today on behalf of everything.
That's really very generous of you. I really appreciate your warmth, the time that you've given to me this morning, and the opportunity to talk to you. Thanks for your attention and for the invitation.
Thank you very much.
Thanks. All right, very good.